Sure. Hi, everyone. My name is Ray. I'm one of the third year general fellows at the University of Pennsylvania. And Dr. Carver asked me to present this case that I actually early in the year discussed in one of our fellow conferences. This is actually a case that I saw as a consult fellow as a first year, so a few years ago now. So I'll get started. I have no disclosures, and so the case is a 57-year-old woman. She has a history of metastatic breast cancer who presented to the emergency room with 2 weeks of dyspnea and palpitations. I was a cardiology consult fellow, and I was consulted for an abnormal EKG. So I'll start there. So I was sent this EKG, and I'll just describe it. I showed sinus tachycardia with a normal axis and some inferolateral ST depressions. Which for reference, this is her only baseline in our system at the time, which did not have those ST depressions in the inferolateral leads. Just in talking to her, her presentation was that about 2 weeks prior to the presentation, she started to develop sudden onset exertional dyspnea with some palpitations as she exerted herself. Her symptoms actually progressed pretty rapidly, and within 3 days, she could not walk for more than about 10 steps without needing to stop and rest, and she would get very short of breath and feel palpitations every time. She contacted her oncologist, and a chest CT and with IV contrast and a transthoracic echocardiogram were performed, which were both reportedly unremarkable. So her symptoms then continued to progress over the next week. She was instructed to get some blood work, which demonstrated pancytopenia with a hemoglobin of 7.4 from a baseline of 9. She is on chemotherapy, and this is not unusual for her. The oncologist felt maybe the shortness of breath was due to symptomatic anemia, so she was set up for an outpatient transfusion with 2 units of packed red blood cells, but there was very marginal improvement in her symptoms. So this is about 10 days after the initial onset of her symptoms. Actually, the day after she got her transfusion, her symptoms drastically worsened. She woke up, and when she was getting out of bed to get dressed, she actually experienced pretty profound presyncope, almost passed out and fell. So it prompted her to check her pulse ox, which was 75% at that time. And so she presented to the ER. On review of systems, positive for the progressive dyspnea exertion and exertional palpitations, like I've mentioned. She's also noting some new sinus pain that's kind of been present over the last 2 to 3 weeks. She denies fever, chest pain, orthopnea, PND, and also no swelling. Her medical history is only notable for the breast cancer, which I'll get into a little bit in the next slide. She has no significant family history. She is a non-smoker, non-drinker, no illicit drug use. Her medications for her breast cancer, she's on atezolizumab and carboplatin, and then she's on an NSAID, pregabalin for neuropathy, and ropinirole for restless leg. So her oncologic history is that in 2017, she on a screening mammogram showed BRAF5, and that prompted a biopsy, which was positive for triple negative ductal carcinoma. She had a CT at that time, which showed bone metastases that were later confirmed to be cancer with biopsy. In October of 2017, she was started on capecitabine and Zometa with initial response in the breast and bone, but about a year later, she had disease progression. So she was then switched to carboplatin and atezolizumab every 3 weeks, along with Zometa, which was held in December of 2018 due to radiation therapy for her hip. As at the time of her presentation, she had received about 6 doses of her of this current regimen, and her last dose was about 1 month prior to admission. In the ER, her labs, she has some basic blood work again. Her labs are notable for a potassium of 2.6. Her creatinine was mildly elevated at 1.0, which was up from her baseline of around 0.5. She continues to be pancytopenic, though her hemoglobin has increased from her outpatient value to 10.4 from 7 after the 2 units. She has a mild AST elevation at 50, a mild alphos elevation at 129. Otherwise, her panel was unremarkable. Basic infectious studies in the ER showed a negative nasopharyngeal viral swab, and they collected blood cultures which were pending at the time. Other studies that were done in the ER, just looking for sort of side effects of her regimen, is a TSH, which was normal, cortisol was normal, was a random cortisol level. Her lactic acid was also normal. And she had an anti-proBNP drawn, which was elevated at 4,758 picograms per milliliter. They checked troponin T, cardiac troponin T, and that was within normal limits on 3 subsequent checks. So on my exam, vital signs when I saw her, she was afebrile, she was tachycardic to 130, and with a normal blood pressure of 115/75. She was mildly tachypnic, and sat in 98% on 2 liters of nasal cannula. She was fatigued and chronically ill appearing, and her otherwise exam was notable for cardiovascular exam, notable for prominent P2, a 2 out of 6 holosystolic murmur best heard at the apex, and a RV heave with a mildly elevated JBP at about 6 to 8 centimeters. Her abdominal exam was unremarkable. So this was actually her echocardiogram from the initial echocardiogram as an outpatient, and let me know if you're unable to see. So this was when her symptoms first started, and this is the echo that her oncologist had ordered. And really, you know, like she reported, it was read as pretty unremarkable. LVEF was normal at 55%. And they called, you know, trace mitral regurgitation and trace tricuspid regurgitation with grade 1 diastolic dysfunction. And this was the sort of the official read on that. This was the outpatient chest CT. Again, nothing too remarkable here. On the left is the lung window, on the right is the vascular window, and you can see there's no evidence of a large pulmonary embolism, and she doesn't have any significant lung parenchymal disease at that time. She has some left axillary nodes which were stable from her prior scans. And this was the official read of that. They called a new small right upper lobe nodule, which I actually was unable to find, but they sort of unclear significance. This was a chest X.
Right.
Yeah.
I just want to interrupt and did it in the brief look at the CT scan. There was no obvious coronary calcification.
Yeah, that's a good point. Yeah, I should have mentioned that. Yeah, no coronary calcification on the non-gated but useful CT. Yeah. So her chest X-ray sort of similar to what we see on the CT, clear lung fields, you know, sharp phosphorentic angles, no evidence of effusion, a normal cardiac size and silhouette, very, very unremarkable. So since her symptoms progressed and she's now in the ER, a repeat echocardiogram was performed, and these were the findings. So now, you know, very different from 2 weeks ago. On the peristernal views, you can see that the RV is enlarged with evidence of pressure overload and abnormal septal motion here on the short axis on the right side.
And Ray, that CT that you showed, how close in time was it to your that echo?
That was the same day as the initial echo.
So about 2 weeks from this other echo?
Yes, 2 weeks from this other echo, and about a day to 2 days after her symptoms started.
Okay.
So just to kind of, so we were here. So on the apical view, you can see a severely enlarged right ventricle with at least moderately reduced systolic function. They're very different from our prior study 2 weeks ago. The left ventricular systolic function appears normal, though slightly underfilled now with the enlarged RV, and there is mild tricuspid to moderate tricuspid regurgitation that's seen in the subcostal view. And just to highlight some of the other studies, so on the pulse wave Doppler of the right ventricular outflow tract, you can see missed systolic notching, and the tricuspid regurgitation gradient was maxed at least 44 millimeters mercury, which was elevated from prior. Her IVC was collapsible but dilated with an estimated right atrial pressure of about 8. And just to sort of put the two side by side, a significant progression of RV dysfunction in size over about actually less than 2 weeks, 9-day period. And this was kind of the formal read of that echocardiogram. The second echocardiogram, what I described, EF of 55%, moderately elevated pulmonary artery systolic pressure, estimated in this one to be in this echo to be about 56, which was 54, which is from normal before.
So it's curious that if you had all that information, the echo and the CT and the previous EKG, and now you had some ST depressions as your only real marker of some change, you must have been compelled from her symptoms must have really changed a lot.
Yeah. Based on talking to her, it's the same character. It's just a lot more severe. So she started with being unable to climb her stairs, feeling more short of breath and resting for 30 seconds to 10 days later, not being able to get out of bed to get dressed.
Yeah, because just in general, your average patient is getting chemo. You're not going to be likely to get an echo in 2 weeks. Something must have really changed.
Yeah. Well, the echo, she came to the ER and she was hypoxic in the ER. I think that was also what drug she had and so tachycardic. So I think just based on her second presentation, they wanted to check again, despite it being so normal in the first one. And she had an abnormal exam. I think that was another thing. Her cardiac exam was pretty abnormal, so it compelled us to check.
Sure.
So just to talk a little bit about mid-systolic notching, I'm sure you guys know. So the significance of that being that it's been described in patients with elevated pulmonary pressures and echocardiogram before. And I'll kind of this was a study actually done by some of the faculty at Penn, but LSN is late systolic notching, MSN is mid systolic notching, and then NN is no notch. And this is looking at RVOT, BTI on pulse wave Doppler, and it's basically a cohort of patients with pulmonary hypertension, and essentially what they found was that if you had missed systolic notching, you had a higher likelihood of having pulmonary hypertension due to pulmonary arterial disease. You would have a a lower wedge pressure if you compared to if you didn't have notch, you have a higher PVR, a higher transpulmonary gradient. And then again, that's sort of kind of made us think a little bit about whether or not she, what the etiology of her clinical presentation is. And I think because of the profound abnormal nature, she actually did end up getting another CT chest with IV contrast because people were so worried about a pulmonary embolism. And this was the repeat, just to kind of let it play through, but no PE again seen. You can see at least the proximal pulmonary arteries pretty well. Certainly nothing that would explain her clinical presentation. Nothing from the PE standpoint that would explain her clinical presentation. From a lung parenchyma standpoint on the right, pretty unremarkable. They do call new sort of small ground glass opacities, central lobular ground glass nodularity and ground glass opacities, which could be inflammatory. Again, not super helpful, and certainly the degree of it doesn't seem to correlate with the amount of dyspnea that she's having. And this is
she sat.
So at this point, she is doing okay at rest on 2 liters. And I'll sort of get to that, but it doesn't, that changes. And she she quickly needs, high flow nasal cannula. She would go down to the 70s with any exertion, even on 6 liters of nasal cannula. Okay, and this is sort of the two CTs is looking at what they're calling the sort of the small nodularities, central lobular nodularities that are new from about 9 days ago.
Yeah, I mean, that's not a very impressive CT for the impressive change in her status. And I mean the echo findings were compelling, obviously.
Yeah. Certainly, it doesn't seem like there's anything here to explain and the degree of her echo changes, and honestly, at this point, the degree of her hypoxia as well. So her clinical course is that she then undergoes a VQ scan, which did not show any evidence of unmatched perfusion defects, and she has progressive hypoxia and tachycardia with very minimal exertion. Getting up to go to the commode, she would go up to the heart rates in the 150, 160s. Her sats would drop to the 70s and require basically like a high flow with a non-rebreather to get her to her sats back up. And she would be very symptomatic during all of this, feeling pretty poor.
I have a question just to throw out to the group, and maybe Dan, because you're a heart failure person too. When we're presented with somebody that's short of breath and they desat into the 70s with a little bit of exercise, do you think that that's ever consistent with heart failure?
No, that's almost always a pulmonary process. I mean, for the most part, heart failure, even severe heart failure, is not really going to cause hypoxia, not that much, and I think her RV pressure overload and hypoxia really points to a pulmonary process. And given that she's on a checkpoint inhibitor, you would say pneumonitis, but looking at the CT is really not very impressive. So,
was there evidence of a shunt by any chance in any of the echoes? Did they actually look for shunts?
Yeah, actually, you're cueing me right to my next set. So because of how profound her hypoxia got, she got another echo. RV and LV function and size are similar to the one just from a few days prior. However, and this time they get a little bit of a better TR tracing, and her peak gradient is 55 millimeters mercury on that, and she continues to have the missed systolic notching, as you can see here on the right. And they do a bubble study, and she has She has a grade 2 shunt, right to left shunt.
Yeah, I mean, that looks like it's present, but is that seriously the cause of that hypoxia? I mean,
Yeah,
just,
I think
it's
one of
not
our thoughts,
not a very big shunt if it's there.
right? This is one thing to kind of just mention is that she, this echo is done at rest, and she doesn't have profound hypoxia at rest. So the question is whether or not this shunt worsens with potential elevations in her pulmonary pressure as she exerts herself.
Was RV infarction considered in the differential diagnosis because of the PKG changes?
Yeah, it was, and we thought about it, from the beginning. The things that kind of pushed us away from it, one is that, her troponins were negative the whole time, and two, she's generating pressure. Her pulmonary pressures are high, and so it didn't feel like it was a primary myopathic process to us. It seemed like the RV was responding to elevated pulmonary pressures rather than, the RV size, the IV dilation coming from a sort of an RV infarction or myopathy. Okay, so right. I think I agree. The degree of shunting is not very profound, but I think whether or not that changes with exertion for her, it's unclear. We don't do anything to provoke the shunt.
Yeah, but I mean, the other thing is that that seems still a stretch, because if you have somebody with essentially a normal echo 2 weeks before, who now presents with, RV dilatation, evidence of significant pulmonary hypertension, a small PFO or even an ASD, if that's what you're talking about right there, it's not big enough to cause RV failure in 2 weeks.
Yeah. I think the way we were thinking about it is that it's probably not causing the RV failure. It's probably, we thought maybe it was contributing to the hypoxia, and probably it was a stretched PFO due to elevated pressures on the right side and elevated size on the right side. But I agree, it doesn't, you couldn't really kind of conceive of a way that this could cause RV failure so quickly.
Yeah, so Dan, the exact right word is stretch. So, yeah, so it's there, and it's now a little more prominent because the pulmonary pressures are elevated, but probably not the cause of the pulmonary hypertension.
Yeah, and I mean, I think that bubble studies are certainly one way to detect a PFO, but I mean, many times a bubble study is called positive because you see a few bubbles over there, but that's not even a clinically relevant PFO. In this case, I would say you do have sort of a mild to moderate amount of bubbles on the left side, but still, that there's just no way that that's causing 2 weeks worth of hypoxia and RV failure in a patient.
Yeah, I think that's right. Like, and it's clearly not the primary process here. So just to summarize her clinical presentation, she's 57. She has a history of metastatic breast cancer with evidence of recurrence while on an immune checkpoint inhibitor, who's presenting with rapidly progressive pulmonary hypertension and RV failure. That's kind of the way I was thinking about her and the way we were going constructing her differential. And just to kind of go through this, what are the reasons why a patient with cancer getting treatment can have pulmonary hypertension, and thinking about the two big groups, cancer therapy related or cancer related, or sort of true unrelated, which the most common cause would be, well, the PE would be one of the other things which we already kind of pretty convincingly ruled out. For her, the things that she is on an alkylating agent, though the one that she's on, cisplatin, has not been associated with group 1 pulmonary arterial hypertension. Some of the other ones have. She's had radiotherapy to her breast, but that was pretty well, it's about a year and a half ago, and it doesn't really fit well with the course and the degree of severity for her clinical presentation. In terms of cancer related, there's certain cancers that can invade the pulmonary vasculature. There's clots or sequelae of chronic clots like CTEPH. There's metastases to the pulmonary lymphatic system that can cause pulmonary hypertension. And then there's also an entity called pulmonary tumor thrombotic microangiopathy, which is sort of a spectrum of things from lymphatic spread to tumor emboli. And it's essentially that there are tumor cells in the pulmonary vasculature that create a pro-inflammatory and pro-thrombotic state that elevate the pulmonary pressures.
So, because of the things you're bringing up, I think, this is an excellent exercise thinking about the differential. I would also add, this would seem like a super red herring, but, in the case of somebody who does IV drug abuse, a lot of times the thing that the drugs are made in, the solution, the content of the drug, the illicit drug has, some non-soluble particle in it. And then if they do recurrent, IV drugs, you end up getting a picture like this, where you get pulmonary hypertension related to tiny little micro infarcts, from the carrier which the drug is in. Now, so going to this lady, not that she was doing drugs, but rather that, could there have been some contaminant in the infusions that she was getting, and they eventually caused her a problem? I mean, that's a thought. I mean, I don't know if it was considered or if it was possible.
Yeah, I don't think we considered that, but that's a good thought. I've heard about the IV drug phenomenon, but I hadn't thought about a contaminated batch of therapy. That's a good thought though.
But that in the early days, that with paclitaxel, that it was put together with something called chromophore A, I think, or something like that, that was the cause of cardiac toxicity. And I think they reformulated it after it was recognized. Chromophore A, I think it was called. And that was the standard way that it was presented. So that's a good point, Dan.
All right. So just to think a little bit about kind of what could side effect of cancer treatment as a cause of her pulmonary hypertension, or her clinical presentation, not necessarily only pulmonary hypertension. The first thing when we got her EKG in her clinical presentation, we thought about is myocarditis or ischemia. Like I mentioned before, there are a few things about her presentation that kind of made us think that it was less likely. Her biomarkers, at least for ischemia, were negative. She has this RV predominant picture, which would be pretty unusual, though not impossible for ischemia or myocarditis. And then the fact that her PA pressures are elevated kind of made us think that maybe the primary process was in the vasculature, not necessarily in the heart. So vasculitis, there have been case reports of vasculitis in immune checkpoint inhibitors. None that I can actually find with her specific PD-L1 inhibitor, but certainly with other immune checkpoint inhibitors. The case reports are of giant cell arteritis and aortitis. There's been no case report of sort of vasculitis of the pulmonary vasculature, but you can conceive that if she does have inflammation in her pulmonary vasculature as a side effect of her immune checkpoint inhibitor, that could raise her pulmonary pressures. But I think it would be rare and probably unlikely, though again, these are new medicines that we are still learning about. Pulmonary venous occlusive disease and other pulmonary arterial diseases have been described with alkylating agents and radiotherapy, and that's on our mind. But why would she present now, over a year after she's gotten the therapy and so rapidly? It doesn't seem like it's not consistent with sort of the described clinical course, which generally is more consistent with a more insidious progression. And this is just kind of a review of immune checkpoint inhibitors and their cardiotoxicity, and a lot of you in the audience probably know a lot more about this than I do. But as you guys all know, immune checkpoint inhibitors, they're basically trying to inhibit the cancer or tumor's ability to evade the immune system. In general, one of the ways that a cytotoxic T cell can recognize tumor cells is through the presentation of tumor antigens by the antigen presenting cells through MHC to T cell receptor interaction that requires a co-stimulation between B7 on the antigen presenting cell and CD28 on the T cell. That then causes the T cell to express sort of antigen recognizing T cell receptors that can recognize tumor and act on them. The tumor can evade this process through a few means. One is that they can express PDL1, which is a membrane protein that can bind to PD1 on the T cell and inhibit them. The immune checkpoint inhibitors act on various parts of this pathway. They act on so you can block the PDL1 on the cancer cell. You can block the PD1 on the T cell. You can also block CTLA4, which is a inhibitory co-stimulatory receptor on the T cell. And all of these, or a combination of these, can help suppress the tumor's ability to evade the immune system. What this does to cardiomyocytes is largely undefined right now, but we do know that it can cause cardiotoxicity. Initially, the initial trials, it looks like the rates were low, but now we're more recognizing that that it can do a variety of things in the heart. Myocarditis is the most common side effect, but it can cause a Takotsubo-like syndrome, arrhythmias, can cause pericardial disease and vasculitides, like I mentioned before.
Yeah, so Ray, this is a beautiful slide, but I would still argue differently that myocarditis is not the most common. It is certainly the most feared. I think we're just learning about the other toxicities that are probably less severe than myocarditis, and they probably occur more commonly. So those would be, even AFib or some rhythm disturbance.
Right.
Heart failure, could even be, diastolic heart failure, and then acute coronary syndromes or some less than acute coronary type event are fairly common. So exacerbation of known coronary disease, and maybe that's some form of vasculitis. So I think that we're still learning about the rates of these events. Definitely myocarditis is the most worrisome. Yeah,
and I think that speaks to kind of how this data has developed over the years. As I was reading about it, there was a lot of reporting up front, and that only the severe cases were being reported, and so probably a lot of the other side effects were just going unrecognized.
Yes, I mean, I agree, Dan. This is like the COVID virus. This plays out longer and longer, and more indications and more people getting it. There's stuff that we don't even understand and hasn't been even recognized. And it may be that it causes pulmonary vasculitis, and and that's why she's got pulmonary hypertension. And it wouldn't be unusual for troponin to be negative if that was the case, right?
Yeah, I mean, clearly something dramatic has changed in just 2 or 3 weeks. So, and you know, some form of itis, you have to decide where that itis is, you know, I mean, this is a great slide, really pretty. So
Thanks. And just kind of this is from a year ago, but this is just a summary of a pharmacovigilance study from a WHO database looking at the prevalence of cardiac adverse events on an immune checkpoint inhibitor compared to other cancer therapies, and basically myocarditis, you're 11 times more likely than in the registry to have it if you're on immune checkpoint inhibitor than the full database. And then there's rates of the other ones, other side effects like I mentioned before. And then the other thing to point out is that you're much more likely to have these side effects if you're on a combination therapy versus a monotherapy with the immune checkpoint inhibitor.
but I mean, still the real challenge, I mean, this is important data, and you know, yeah, it's a pharmacovigilance study, so that's all after the fact. But right, if you see 100 patients that are on a checkpoint inhibitor for the next week, you see 100 of them, and you see them for a whole host of cardiovascular issues, you know, out of that 100 patients, I doubt very seriously you will come up with a diagnosis of vasculitis in a single one of them. Even if you see them for all sorts of vascular related problems, you just don't come to that diagnosis. And so when you're looking at a pharmacovigilance study, it's looking at after the fact, a diagnosis that was made. But if people aren't thinking about that diagnosis, they will never make it. And so even the rates of myocarditis are going to be vastly underreported because, you know, the only way that you diagnose myocarditis in most cases is probably at autopsy.
Right. That's a good point. And yeah, and actually just thinking about it, looking at this list, myocarditis actually may be one of the easier ones just compared to vasculitis and some of the other entities, because sometimes it's defined by biomarkers.
Yeah, so it's new onset AFib.
Yeah.
A patient who previously had a normal heart and now they develop new onset AFib. Is that potentially a manifestation of low-grade myocarditis? Certainly seems possible to me.
Right.
But in your diagnosis, if you saw that patient and, you know, they were a patient with breast cancer is being treated with chemo and they go into AFib, you're not going to think any bit about it. You're just going to say, oh, they got AFib, I'll do my usual stuff, and there you go.
Yeah. Yeah. Thanks.
And you certainly wouldn't think of giving them high-dose steroids for atrial.
No, of course not. And the other thing is say they came in with an acute coronary syndrome. You know, let's just say it got that bad and they presented with an acute coronary syndrome, you would take them to the cath lab, you do your usual stuff, put them on a stent and call it a day. You wouldn't go to that next place and say, what was this a manifestation of a deeper problem?
Yeah, so I guess so you guys wouldn't necessarily like even think about changing the therapy or if it was ACS, something that you could explain otherwise.
I don't know. I don't know what people do at other places, but you know, I think that just knowing cardiologists in general, if somebody comes in with an acute coronary syndrome, they're going to go, at least at WashU or wherever I've been, they're going to go to the cath lab, they'll get a stent, and then they'll be discharged either that day or the next day.
Right, right. Yeah. Yeah, that's interesting. Just to kind of move on, so incidence is largely unknown of the myocarditis, between 0.3 to 1%. Again, like with all of the caveats that we mentioned already, it's believed that most of these occur early in the course of treatment with a median time of onset of 30 days. Again, this is only looking at the identified cases, like we've mentioned, and then combination therapy is a predominant risk factor, which is really a predominant risk factor for most of the immune related side adverse events of the checkpoint inhibitors. Prognosis is thought to be poor, with a possibility of as high as 50% mortality. Again, there could be reporting bias here. And histologic examinations of these showed lymphocytic myocarditis. And this is just something that was pretty educational for me personally. This was just a case report. It was one of the first case reports of immune checkpoint inhibitor myocarditis, published in 2018. And one of the main takeaways is that EF is not very sensitive or specific for this. Probably the most sensitive therapy, diagnostic is biomarkers. But again, it's sort of conflated with how they're being defined. A majority of patients have abnormal EKGs. Again, these are all patients with believed to have immune checkpoint inhibitor myocarditis, diagnosed a variety of ways. Some was on autopsy, some was on biopsy, and some were just positive biomarkers with MRI findings, or positive biomarkers with LVEF changes. And this is just looking at when the onset between the 35 patients, and you can see that the majority occurred pretty early. Treatment for this depends on disease severity and response. ASCO guideline is 1 to 2 mg per kg of prednisone, or 500 to 1,000 to a gram of methylpred. If refractory, consider infliximab or mycophenolate mofetil. And then there's what I saw case reports of thymoglobulin, Rituxan, abatacept, and some other meds used. So that's kind of, we felt like if this were a side effect of her immune checkpoint inhibitor, it would be like a new description of pulmonary vasculitis. But there was something else. One of the other things in our differential was actually pulmonary tumor embolism syndrome, and it was something that we were pretty concerned about. The concept here is that tumor cells can get in, a significant number of tumor cells can get into the circulation and become trapped in the pulmonary circulation, that trigger sort of obstruction via pro-thrombotic and pro-inflammatory mechanisms. Interestingly, this isn't considered to be a true metastasis, because when they examine these cells, they find that they don't actually have the cell surface proteins required to sort of attach and adhere to the lung. So it's believed that they actually do travel through the circulation and just get lodged. Clinically, this presents with dyspnea and hypoxia with pulmonary hypertension and rapidly progressing RV failure, which really fits with our patient. And this almost always progresses to obstructive shock. Clinical incidence is unknown, but believed to be pretty low. There's no registry of this. It's only case reports. But it is observed in up to 15 to 25% of autopsy studies. So probably underdiagnosed. It's most commonly seen, based on what we know, in renal cell carcinoma and other adenocarcinomas. And one of the case series of like 20 identified on autopsy, only one of the 20 was diagnosed before death, and it was all believed to be the cause of death. So again, the diagnosis is probably pretty underdiagnosed. Prognosis is extremely poor. I actually could not find a clinical example, at least published, of someone surviving this. It's believed to be an end-stage manifestation of cancer. In the diagnosis, the gold standard is autopsy or a biopsy, but if that can't be done, there's reports of using VQ scan, which our patient had normal, or wedge cytology, which is basically getting a blood sample in the wedge position with the balloon up and sending that to cytology. So that's what our patient was the next step for our patient. She underwent a right heart catheterization with wedge cytology. Her hemodynamics was notable for a normal aurary pressure of 5. Pulmonary pressure was severely elevated, 70/28, with a mean of 41 millimeters mercury. She had a very low pulmonary capillary wedge pressure at 4 millimeters mercury, with at the time relatively preserved cardiac output index at 2.2 liters per minute per meter squared. Her pulmonary vascular resistance was severely elevated at 10 Woods units, and her SVR was 19 Woods units. And the cytology actually came back positive for basically ductal carcinoma, which was morphologically similar to the patient's known breast primary.
So wow, that's really fascinating. So what made you decide to get cytology from the wedge?
Well, it was actually something that, by this point, we were on, and actually my attending on the general consult service was Rupal Quinn, so she was sort of familiar, and the pulmonary hypertension was also involved, and that was something that we actually kind of discussed pretty early, this as a possible explanation. I think just because of how rapidly progressing her symptoms were, I personally did not know about the etiology until it was brought up in our discussions, but after reading about it, it fit her clinical course pretty well. And the other thing is that, and I didn't highlight this as much, but on her CTs, more recent CTs, she has shown some small progression of disease, nothing that would have by itself explained her symptoms, but that kind of raised our suspicion too. So she was then transferred to the oncology service. She was on the pulmonary service at the time. She was started on sildenafil, which we were all very hesitant to do, but we didn't really have any better options at the time. We wanted to get her hypoxia under control. And we thought maybe if the shunt was contributing, that could help. But again, we don't. If this was tumor emboli, we actually didn't fully expect pulmonary vasodilatation to help, because there would be a fixed obstruction and we may worsen her pulmonary edema. She did actually become more hypoxic, so we backed off on the sildenafil. She ended up being on high flow nasal cannula, and things sort of settled down. And we got a lot of different teams involved, including oncology, pulmonary hypertension, cardiology, palliative care, basically deciding on next steps. And she was pretty sure that she wanted to at least try more chemo, even though it wasn't our expectation that it would be it would be difficult. It wasn't something that we felt like would definitely be helpful. So she did get a dose of Abraxane about a week after her presentation, and she actually decompensated that night, went into shock, and was transitioned to comfort care and passed away peacefully in that ICU.
Do you have the right heart cath findings by any chance?
The right heart cath what?
Findings, sorry. The numbers.
Yeah, here they are.
Oh, okay, good. Oh, okay.
Yeah, I mean that is a striking case, and the idea that you would do cytology from a wedge is that's pretty cool, I have to say. Now it's very unfortunate that it came up positive. It's like your worst nightmare.
How did you do psychology?
I think one question I had, which I don't know that there's a good answer to this, is that we don't send routine blood work to cytology. So to what extent is this, we don't have like a negative control here. It's not like we take cytology and find negative. So I do think there's a little bit of bias here in that we're only checking in patients with symptoms, and so we don't know what pulmonary blood samples are like in people with normal pulmonary pressures but metastatic cancer.
Well, I mean, I think it's an extraordinary thing. I mean, obviously, I've been seeing these kind of patients for 25 years and I've never done that. So this is a new one. So
yeah, there are some case reports, mostly in the pulmonary literature, some with like prostate cancer, renal cell cancer, but this was actually the only one I've seen with breast cancer.
amazing. Bad
Greg,
for her.
one of the participants is asking, how do you obtain a cytology sample from the wedge?
Yeah, so it's the same as if we had gone, it was pretty similar. We just got a second syringe. We generally draw blood, well, from the PA when we do a right heart catheterization. We just have the balloon up with the catheter in the wedge position and draw distal to the balloon.
Yeah, so we used to do that quite frequently, especially when we were doing, detailed hemodynamic studies to confirm that you were in a wedge position. So you would do a saturation on the wedge sample, and it needed to be in the 95% range. So I mean, it has been done in the past, but most of the time, certainly in the routine cath lab material, nobody's going to check a wedge sat. Nobody does that, so you had to be very intentional to actually get this. So it's extraordinary. I think it's an amazing idea. So
You get through a balloon?
yeah, I think you got a big echo there.
Yeah.
Yeah, I'm having trouble understanding you. I'm sorry.
Yeah. So they can, if somebody has a question, they can send it via chat. It's at the bottom of the options on the screen, and you type it in, then we can try to answer it. But yeah, this is a fantastic presentation. But man, what an impressive change.
Yeah, it was so striking. I actually was I was on call and I ended up doing, so it was a very striking echo. That's why I remember it so well, is because she actually looked pretty well at the time of her second echo.
And prior to this sudden change, I mean, she was very functional, or?
Yeah, it made it difficult. She was well supported, very functional, like very independent person, and really had no cardiovascular or exertional symptoms before 10 days prior to presentation.
Oh, I wonder if you got a PET CT, if the pulmonary arteries would light up.
Yeah, I mean, I think one of the things is how do you diagnose this at the time of her initial it's hard to know, but you can imagine that maybe there was some period, very brief window of time where she may have been more likely to respond to treatment. But how do you diagnose something like this when she had a normal echocardiogram and a negative chest CT? It's difficult to say.
Yeah, I mean, with the previous, 2 weeks before, you had an echo and a CT that was pretty unremarkable. It would be major league stretch to say, oh, I got to do a right heart cath and do wedge cytology.
Right.
For somebody who has normal EF, no evidence of pulmonary hypertension, and a normal CT.
Yeah. and her VQ scan ended up being normal. That was actually one of the ways we initially tried to diagnose it, because the case reports showed some characteristic VQ findings, but she didn't even have the abnormalities there.
Wow.
Ray, a couple other questions. It looks like one person is asking, was a peripheral blood sample sent to cytology, and is it expected to be negative in this case?
Yeah, so we didn't send one, and that was one of my that was what I was referring to before. I don't know what we would expect. I looked into it briefly, and I couldn't find. I don't think it's something that's been looked at. Is what happens in a peripheral site, like can you find circulating tumor cells in these patients? I'm not sure.
There was a study a few years ago in patients with sarcoma that had a DVT, and they actually, extracted the DVT. I'm not sure how they did that, with some angiomax or something. But anyway, they extracted the thrombus from these patients that had, big DVTs, but a history of sarcoma, and were able to find sarcomatous cells in the DVTs. So,
Oh, wow.
I think that was, a handful of cases, but nonetheless implying that one of the mechanisms for people to have recurrent DVTs, with a history of cancer is actually tumor thrombus.
No.
Kalyan, did you want to ask a question? Kalyan Chituri? No, Masood?
Yes, thanks for your fantastic presentation. I want to ask you a question. What is your plan for this case? And for the first question, and the second one is, do you start any anticoagulation, for example, for microangiopathy? As we know, maybe we have some microangiopathy, but RCT was normal, of course. But maybe some reason of the systolic pulmonary arterial hypertension is for that and for the cancer and the cause you say. And should we start any anticoagulation for this patient?
She was on empiric anticoagulation. She was on heparin for I would say the majority of her hospitalization. Despite the negative CT, I think it was just something that felt like the risk benefit favored just empirically treating. I think that I don't think that there's much evidence for that, and especially given that the degree of her RV dysfunction. There's certainly the CT chest could have missed some small clots, but nothing that would have explained her cardiac presentation. So we felt like it's very unlikely that ultimately this was a thrombotic sort of event.
Yeah, I think that there's some evidence, in all comers of patients that develop significant pulmonary hypertension that anticoagulation may reduce some of the longer term toxicities from that. But it's not very strong data. And I think just like in your case with this patient, you had them on heparin, presuming that, possibly there was some small thrombi, and you were trying to prevent that from recurring because this patient wouldn't be able to tolerate that. But
right.
Aside from doing it because it seemed like it was a good idea, we don't really have a lot of evidence.
And what's your management for this patient?
Well, she received a dose of chemo, but unfortunately she decompensated and passed away.
Okay.
Hi, Ray. This is Cal.
Thank you.
Hi, Ray. This is Cal Chaturi. A very interesting case that you presented. I had a question about the pulmonary vasculitis theory. I think that has a lot of credence, actually. Maybe like a pulmonary microvasculitis. the microvasculature can cause this, but we don't really know. I was wondering if autopsy was offered for this patient.
Yeah,
Her family.
We offered autopsies. Yeah, we offered autopsies for I think all of the patients, and the family had declined. I think they felt I think everyone felt like we had a diagnosis and that there wouldn't be an additional answer that we could find. But I see what you're saying, and maybe there's something we could see in the vasculature.
Yeah, I mean, I think the only other possible diagnosis that you didn't treat for really would have been, some constellation of pulmonary vascular problems resulting from the checkpoint inhibitor. And then you could have given high dose steroids. But even then, if that was your diagnosis and you gave high dose steroids, I think she still would have died because, it's like, you're at the end of the game.
Yes, so
Yeah, and that was. Sorry.
Yeah, go ahead, Ray.
Oh no, we were saying that was the utility of this cytology actually, since we were between the two diagnoses and we were going to either give steroids or have a conversation and potentially offer chemo, depending on the results of the cytology.
And I was going to add that there was like no other evidence of vasculitis or other immune mediated side effect that it would be concomitant. So it makes it probably less likely that it was related to the immune checkpoint inhibitor. So I just want to make a comment that when you I mean, other people that have presented, but when you hear Ray and see the talent that's there, it makes the old guys like us really confident that we have a great succession of people to take over for us as we fade into the darkness. So, Ray, that was awesome.
Thank you so much.
Great job, but Joe, we're not letting you go yet, okay, buddy? So we keep dragging you in.
That was a great case.
Thank you.
Fantastic.
Well done.
Yeah, thank you, Ray. To wrap up, really appreciate it. Excellent case.
Thank you so much. Very nice.
Thank you, everyone, for being on this morning or this afternoon or this evening.
We have which presentation next week? Do you know, Steve?
Next week is COVID related.
Is it Dr. Noria?
Yes, Anju Noria.
Perfect.
And then we have Brazil tonight, right?
And there's a webinar tonight, another case presentation at 7 p.m. Eastern time.
All right, very good. Thank you all. Appreciate it, Ray.
Excuse me, before hanging up, may I ask a question? This is Shadi Zandi. So my question is anybody sent any vasculitis workup for this patient? Like Pianka, Sianka, and the rest of vasculitis workup? Yeah,
I'm trying to remember.
Because I did not see that in the slides.
Right. Yeah, I think an ANA was sent, but not an ANCA. If I want to remember correctly, I can look into that and get back to you, but I don't think so.
Okay. Thank you.
Yep.
Great presentation. The case was awesome. Thanks.
All right, thank you so much.
Yeah.
Ray, be okay if people have other questions, they can get in touch with you directly?
Sure.
That'd be great. I'll share your email with those who have further questions.
Yeah, that'd be great. Thank you so much.